In addressing this topic, which has become of increasing interest to neurologists and the neurosurgeons, people who treat Parkinson's disease, I think it's very important for patients who are interested in understanding their disease to understand their disease. So the objectives of this talk will be to review the basic features of Parkinson's. That'll be fairly quick. A brief overview of nervous system function. That unfortunately is going to be the part that may put you to sleep. And then go over the importance of dopamine, particularly in Parkinson's disease. But you all have heard about dopamine in other contexts. It commonly is discussed when people are talking about a variety of problems that are related to the brain. To describe to you the limitations of current treatment for Parkinson's disease, and then hopefully to conclude on a more optimistic note about opportunities. Not that something is on the near horizon, unfortunately, but opportunities for better treatment in the next 5 to 10 years. Next slide, please. Let me just briefly, and I'm going to very briefly review the nervous system. I'm going to show you a couple of illustrations as well, but I won't spend too much time. First of all, we divide the nervous system generally into 3 components. You could actually start off in 2 components. One is called the central nervous system, and the other part is called peripheral nervous system. But you can think of it more simply as having 3 components, being the brain, the spinal cord, and nerves. I mean, half of you probably have had sciatica, for example, and that's often caused by, as you've been told by your doctors, a pinched nerve. So you have nerves that go from your spinal cord to the rest of your body so that you can feel things. Those are called sensory nerves because they sense things like when you're being touched, when something is hot or cold, if something is sharp or dull, a variety of things like that. And you have nerves called motor nerves, which are nerves that go to your muscles that help you move. So there are nerves that take information in, and there are nerves that take information out. Those nerves actually are not affected in Parkinson's disease. But there's another component of nerves, which are called the autonomic nerves. Those are nerves that are not under your control. Those are nerves that go to your blood vessels, they go to your sweat glands, they go to your intestines, they go to your stomach. Those are nerves that control your blood pressure. They determine when you have Parkinson's disease that you're getting constipated because the innervation, the nerves going to the muscles in your gut that move things along have been damaged by the Parkinson's disease. Those are affected in Parkinson's disease. And there are people now investigating whether or not, or how often is a better thing to say, how often that precedes the development of your Parkinson's disease. So for example, we know that by the time people are diagnosed with Parkinson's disease, most patients already have problems, at least abnormalities. They may not be causing problems yet, but they're on the way to causing problems. There are abnormalities in the autonomic nerves. There's a study going on now where they're looking at old biopsies from colonoscopies in patients who, 5, 10, 20 years later develop Parkinson's disease to determine whether they might have seen the beginning of Parkinson's disease even earlier before it developed. So autonomic nerves are affected in Parkinson's disease. The spinal cord is not, as far as we know, affected, but the brain, of course, is. Now, in general, we've always considered, myself included, Parkinson's disease as a brain disease, and it is a brain disease, but it also involves the autonomic nerves, and that can be a very big problem for people with Parkinson's, particularly in terms of constipation, in terms of something we call orthostatic hypotension, which is a drop in blood pressure when you stand up, so you get lightheaded or your legs feel wobbly or you faint. and in terms of bladder activity, overactive bladder. So those are all part of the Parkinson's, and they're all unrelated to dopamine. You probably already know that when you've taken L-Dopa, carbidopa, levodopa, or Sinemet for your Parkinson's, you know, you may shake less, you may walk better, you may move better, but it doesn't help your constipation any. Doesn't help your bladder any, and it doesn't make your blood pressure any better when you stand up. So there's a problem with thinking of Parkinson's disease as a dopamine deficiency disorder as the only feature. Now the brain, and I'll try to go through this quickly. The brain is composed of different types of cells. There are nerve cells or neurons, but there are also other types of cells that are mostly supportive cells. They don't actually contribute to the circuits that are formed within the brain. We don't think that they're involved other than providing supportive services for, say, moving, for seeing, for thinking. And then, of course, there are other kinds of cells, like there are blood vessels in your brain in particular, and then there are some other supportive structures. And then there are nerve cells themselves. I'm going to show you a very easy cartoon, a relatively easy cartoon. Can you show that? So this is a nerve cell. In this part, which So this is a cell body. When you look under a microscope and you look for a neuron, this is what you see. And it communicates, it sends a message down a very long, thin filament called the axon. It receives information from parts that are called dendrites. What's important for us in the next slide are the connections that the nerve cells make. In your brain, there are a lot of cells, and these cells each communicate with other cells, and they form circuits. You can think of it as being analogous to computer circuits, but I'm going to show you that it's much, unfortunately, more complicated than that. So cells connect with each other, and the way they transmit information is by secreting or putting out a chemical. So in the brain, there are nerve cells that make chemicals. These chemicals are enclosed in little packets. The packets are then pushed out over here, and then it communicates with another neuron or nerve cell or brain cell over here, and that triggers an electrical response. So there's actually a chemical interaction between one nerve cell and another, and the next one produces an electrical response, and this one then communicates in the next cell in the same fashion. Next slide. Now, those are called neurotransmitters because they transmit information. Dopamine is a very important neurotransmitter in Parkinson's disease, but it's not the only one. There are at least 16 different neurotransmitters, and then there are other chemicals that are very important for normal brain function. Dopamine is only one of the 16, and then there are a lot of chemicals that affect how the neurotransmitters work. So think of the brain working as if there's a cell that it communicates with another one, so it triggers, say, a ring, say, like a telephone. And then the next cell picks it up, and that transmits another ring down the line to another cell, which then picks it up. Now, in Parkinson's disease, it was recognized back 100 years ago that people with Parkinson's disease have a decrease in the cells in a particular part of the brain, which is called the substantia nigra. Now, just because that sounds fancy, what that means is black substance or black body in Latin. Really not so fancy. If you called it the black body, nobody would be impressed. But if you use Latin words, everybody's impressed, and it sounds like you know something. So in Parkinson's disease, you can see, at least in this illustration, that there's a marked reduction in these cells. So a neuropathologist can look at the brain of somebody who died and say, gee, this person doesn't have any cells in the substantia nigra, maybe that person has Parkinson's disease. There are other conditions that can cause that. Next slide. So this is a specimen, two specimens, one from normal person, one from person with Parkinson's, and you can see that there's a decrease. It's not as prominent as in that illustration we saw, but that's why they have the illustration to make it much more clear-cut. So there's a pallor, a decrease in the number of dark cells, pigmented cells, here versus here. And on the next slide, what it looks like under the microscope is that all of these blotches here are normal. That's the way you're supposed to look. But when you have Parkinson's disease, you can see there's a lot fewer of those cells than there should be. So in Parkinson's disease, there's a decrease in these cells in one particular region of the brain. That's what everybody's focused on for the last, for most of the last 100 years. But unfortunately, it turns out that there's more widespread damage than just that. So let me talk about dopamine. The story of dopamine is actually quite interesting. Okay? Back in the 50s, the 1950s, people, psychiatrists, counting them as people, count neurologists as people, psychiatrists as people. So back when doctors were experimenting with treating schizophrenia, and one of the drugs they used first was a drug called reserpine. Reserpine is a drug that at that point was being used to treat hypertension, high blood pressure. And the reason they were interested in reserpine is that when they gave reserpine to animals, it slowed them down. And that was thought, for whatever reason, to be a good thing for people with schizophrenia. Now, some of you may have some contact with people who are schizophrenic, but if you don't, they're not running around. It's not like they're jumping up and down and bouncing off the walls. They look like everybody else. So why you would want to slow them down isn't clear to me. But they decided that would be a good thing to do. And what they learned from their experiments using reserpine to treat schizophrenia was, number one, it didn't work. It didn't help patients' psychiatric condition at all. And it made people look like they had Parkinson's disease. So somebody very smart got the idea of saying, well, gee, we know how reserpine works. Reserpine reduces a certain type of chemical in the body. It works to reduce blood pressure by reducing adrenaline. Okay. So they decided to look in the brains of people to see what happens to their adrenaline, or happened to their adrenaline, if they died and they had Parkinson's disease, based on the theory that reserpine does this, so maybe that's what happens in Parkinson's. And what they discovered was, in fact, that noradrenaline, which is what the brain has virtually no adrenaline, but noradrenaline is in fact quite reduced, but not nearly as reduced as dopamine. Dopamine is very closely related to adrenaline and noradrenaline. So they got the idea that maybe the features we see in Parkinson's disease are related to the fact that those brain cells in the previous slide are diminished, and those brain cells make dopamine, and maybe if we increase the dopamine in the brain, we can get people moving better. And of course, you know the rest. The experiments showed not so easily. The initial experiments with L-Dopa were not so good, okay, because it made everybody vomit. No, back to last slide. But with further experimentation and thoughts about how to give L-Dopa and get people acclimated to taking L-Dopa, it turned out, of course, that L-Dopa has become the single most important drug we have for treating the symptoms of Parkinson's disease. None of the newer drugs are nearly as good or as important. And now it turns out that dopamine is important in other things as well. And in fact, if you've read about, say, impulse control disorders, or if you've read about addiction, whenever they talk about what goes wrong in the brain of people who become addicts, they're always talking about dopamine. They're talking about the importance of dopamine and what's called reward, that people do things because it makes them feel good in some way, and they feel good because there's dopamine. So I started thinking about this because everything I read about always said, well, dopamine is important for this. And I'm thinking, well, dopamine is important in Parkinson's disease. I see that every day. But it turns out it's important in addiction. And it turns out it's important in virtually every behavior. So I sent an email to a colleague of mine, he's the chairman of the pharmacology department at Brown, and I said, is there any activity in the brain or any behavior that's known that doesn't involve dopamine? And the answer was, he couldn't think of a single one. Dopamine is involved in everything. So dopamine is important in Parkinson's disease, but it's important in a lot of other things. And when you read in the newspaper about dopamine being important in drug addicts, that may be true, maybe not. In Parkinson's disease, we know that it is important. Now, L-Dopa, which many of you are taking, is shorthand for diorthophenylalanine. That's even worse to say than carbidopa-levodopa, which most people have trouble with. So we call it DOPA. The L is a chemical term. Okay, if you have, say, a right hand and a left hand, obviously they look identical, but they're different, okay? One is right-handed, one is left-handed. And so this is a chemical term that refers to how these different atoms are placed to make this particular molecule, which is dopamine. So I just wanted to explain why it's called L-Dopa. Until probably 10 years ago, we always just called it Cinemet, which was the brand name, because that was the only company. There's only one company that made it, and it was a brand name, and it was called Cinemet. It took me maybe 15 years before I started to think about why did they call it Cinemet. The answer is sin is without, I think, and it's without emesis. Emesis is vomiting. So Cinemet means without vomiting. Because when L-Dopa was first developed, a lot of L-Dopa is converted in your bloodstream to dopamine. And dopamine makes people nauseated and vomit. And so when they first gave L-Dopa, that's what it did. It caused patients to vomit. And so they couldn't take enough of it to see the improvement that it caused. And so when they came up with the idea of giving the carbidopa, which prevents much of the L-Dopa from being metabolized to dopamine, you don't see nearly as much vomiting. So they called it Cinemet, which sounds pretty good. But if they, it's like with a black body. You can't call it black body, you call it substantia nigra, and you can't say this pill is without vomiting, because that's obviously not going to be a very good advertisement for it. Next slide. Now, as promised, okay, I'm going to tell you why the brain is a little more complicated than a computer. In that part of the brain, the substantia nigra, where we see a reduction in the brain cells, there are, according to this article, which is one that was just published 2 months ago, there are approximately 382,000 neurons. Okay, that's a lot, okay, but not extraordinary lot. I mean, it depends on what you think large is, but that's enough for me. But the really impressive thing is that each one of those cells, each one of those 382,000 cells, on average, makes a contact with over 1 million other cells. Each single neuron contacts 1 million other ones. That's complicated, okay? So if you have 382,000 making 1 million connections, that's a really very impressive number. I mean, that's higher than I can count. So that's a lot of connections. So the circuitry is extraordinarily impressive at how complicated things are. Next slide. And we know, about the connection between Parkinson's disease and dopamine, besides the fact that L-Dopa makes people worse, is that there are a lot of drugs that actually block dopamine, that interfere with dopamine as a neurotransmitter from stimulating that next cell, from keeping the next cell from being contacted. the antipsychotic drugs, drugs that are used, in fact, for schizophrenia, often cause people to look like they have Parkinson's disease, and they will cause people to become slow, reduced movements. They sometimes develop a tremor, not quite as often as in Parkinson's disease. They become stiff, they develop astute posture, they can develop balance problems as well. So by blocking dopamine, we can make people look like they have Parkinson's disease. Next slide. But we can also make people look like they have Parkinson's with drugs that don't block dopamine. The most common that we see are lithium, which is a drug used for bipolar disorder, people have manic depression, and valproic acid, or Depakote, which is a drug used both for epilepsy and also for bipolar disorder. And those are drugs that do not block dopamine, and yet they can make people look like they have Parkinson's disease. Not most, but some. And I haven't found anybody, and I have asked, to identify what they thought the mechanism was for doing this. So you can make people look like they have Parkinson's by blocking dopamine, but there are other ways of doing this as well. So there are other chemicals involved in the brain that contribute or may contribute to the problems we see in Parkinson's. That's very important because almost all of the focus of drug companies has been on improving dopamine stimulation in some way. Next slide. Now, I told you before that there are different parts of the nervous system in two parts. The brain and the autonomic nervous system are involved in Parkinson's disease. Now, Parkinson's disease, as you know, is considered a movement disorder. I'm considered a movement disorder specialist in neurology. But Parkinson's disease is more than just a movement disorder. And this is a crucial thing to understand because it's really been a concept that has developed among neurologists probably only in the last 10 years or so. And I'll explain this and then tell you how this comes up. So first of all, there are the motor problems. You're all familiar with these. You know it causes tremor, it causes stiffness, it causes slowness, it alters the way you walk, it alters your balance, it alters the way you talk, all sorts of things like that. But in addition, there are these autonomic functions. These are functions that are different than the motor functions. And again, you're familiar with all of these, although a lot of patients aren't aware that this is part of their Parkinson's disease. Because a lot of the problems that people with Parkinson's have also occur in the general population who, people the same age. They don't sell all those constipation products at CVS because they have so many people with Parkinson's disease. Constipation is a very common problem in the general population. Bladder overactivity is a very common problem in the population. But Parkinson patients get these problems a lot more and often more severe. So constipation, I've already mentioned too many times. Orthostatic hypotension, overactive bladder. Some patients with Parkinson's disease develop this terrible problem with sweating, which we don't understand, where they'll just start sweating. Okay, and it's not related to women going through the change. They're not hot flashes really, although sometimes people describe it that way. But some patients get these drenching sweats at night, where they have to change their pajamas. They may even have to change their sheets. And it's totally unrelated to dopamine. Each one of these problems, constipation, orthostatic hypotension, overactive bladder, and sweating, are unrelated to dopamine. You give dopamine, they don't get better. So there's more than Parkinson's to Parkinson's than just dopamine. The cardiac, I'm just mentioning in passing, Parkinson's actually doesn't cause cardiac problems in the sense that there are no clinical problems. But actually you can show that there's an abnormality of the nerves going to the heart in over 75% of Parkinson patients by the time they're first diagnosed. It's not clinically important, at least as far as we know, but nevertheless it's there. And then, of course, the area that I've been particularly interested in, which are the behavior problems that develop in Parkinson's disease. You're all aware that Parkinson patients are frequently depressed, and certainly more depressed than in the general population. Anxiety is a big problem in Parkinson's disease, frequently associated with depression. Dementia, which is a problem with memory and with thinking, is increased in people with Parkinson's disease. Fatigue is a very big problem for people in Parkinson's disease. There are a lot of sleep problems that occur in people with Parkinson's disease, and yet none of these improve with dopamine. So this week I was talking to somebody who was from a company who was asking me about Parkinson's disease, and he was saying, well, something about when people become severe, when people have severe Parkinson's disease. He said, that's not a good concept. If you talk to most doctors, including most neurologists, and you talk about severe Parkinson's disease, I think most people think of a person who's in a wheelchair or could barely walk or has trouble talking, people who are really motorically terribly impaired. But what do you think about a guy who's able to walk by himself, he can get up, he can dress himself, he takes care, totally independent, but he's demented? And you compare that person to someone who's in a wheelchair, but who's mentally completely normal, speaks well, communicates well, who's severe? I think it's a concept that needs revision in the way we think about things. What I pointed out to him is that the concept of severity in Parkinson's doesn't make a lot of sense. I think in terms of how impaired a person is. And that varies from person to person. So you have a university college professor who's a little bit less smart than he used to be. He may be terrifically impaired, he may be disabled. Whereas somebody who doesn't need to use their intellectual function every day, every minute, may not be very impaired at all. Somebody who has Parkinson's that affects their dominant side so that they can't use, say, their right hand very well, is terribly impaired and might not be able to work. But if that person was left-handed, it would be inconvenient, but not really terrible. Severity is a very difficult concept. And so we often focus on the motor aspects, and yet, the other things are, in many cases, more important. I've mentioned before in talks that I've given that in every study, actually, I was going to say virtually every study, but that's not true. In every study, the most important determinants of quality of life for people in Parkinson's disease are the behavioral components. Depression, fatigue, dementia, sleep disturbances, more than motor. And yet, none of those are related to dopamine. So when doctors think, scientists think, pharmacologists think of Parkinson's disease as a dopamine deficiency disorder, you give them L-Dopa, they're all better, that's not accurate. And I think we've moved away from that, or are moving away from that in modern times. So let me talk about tremor, okay? Because everybody thinks that tremor is Parkinson's disease. In fact, a lot of doctors think if you don't have tremor, you don't have Parkinson's disease, and if you're old and you do have tremor, then you do have Parkinson's disease. And all of you know that that's not so simple. So tremor often does not respond to dopamine. That is, it doesn't respond to L-Dopa. So when I start patients, it took me a long time to learn this, but when I start patients on their Parkinson medicines and they have tremor, then I tell them, the tremor may get better or it may not get better, but usually the stiffness and the slowness, the ability to get out of a chair, the walking, all of those things get better. It'll be easier to get dressed, easier to do your buttons, easier to comb your hair, things like that. But the tremor may or may not get better. And in fact, there are some people who have their motor impairment, like the slowness and the stiffness on one side, and the tremor on the other. And when they do studies looking at how much dopamine is in the brain, there's not a good relationship with the amount of tremor. A person may have very bad tremor, but their dopamine looks, a little bit reduced. Whereas if they're slow and stiff, their dopamine is markedly reduced. So tremor, actually, even though it's one of the cardinal features, it's the most recognized feature in Parkinson's disease, is not always related to dopamine. In addition, another peculiar thing about tremor is that sometimes it gets better over time. It's the only symptom in Parkinson's that sometimes actually improves or might even go away. Next slide. Speech. Speech often, so let me just tell you what I'm trying to drive home here. Number one, that Parkinson's disease consists of at least 3 kinds of problems. The motor problems, which is what most people think about, the autonomic problems like constipation and blood pressure and bladder, and then the behavioral problems, okay? And that 2 of those, the autonomic and the behavior, are not related to dopamine. Now what I'm trying to tell you is that even some of the motor problems are not completely related to dopamine either. So speech often does not improve when we give L-Dopa. Sometimes it does, but not usually. It's one of the reasons speech therapy is so important, and it's one of the reasons that we don't generally push the drugs even in patients who are having a lot of speech problems, because they typically don't respond very well to them. So speech often doesn't, and along with that, swallowing often doesn't. Next slide. Freezing of gait. Freezing of gait is a problem we don't understand, just like we don't understand a lot of these problems, where people start walking and all of a sudden their feet freeze to the ground and they can't move their feet. Typically it occurs, or more commonly it occurs, when people first stand up after they've been sitting for a while and they try to take a step and their feet just won't go. It also occurs when people stop. So the most common times for this to occur, besides when they first get out of a chair, is when they try to turn. So they stop and they try to turn and then their foot won't go. They have this sort of stutter step, or some people call it the slipped clutch syndrome. You people are old enough to maybe have driven a standard transmission car. I think the younger people may not even know what that is. But you know, the feet freeze to stick to the ground, and of course it puts people at increased risk of falling, you know, because they're about to lose their balance. And it also occurs to some people when they're about to walk in or out of a room, when they go through a threshold, or for whatever reason it triggers this freezing sort of thing where their feet just stick to the ground. And L-Dopa sometimes helps, but often does not. Next slide. And posture. I mean, you know, it really is such a difficult thing when you see somebody with Parkinson's, you know, who has a stoop posture and they really just can't get straight, and it hurts too, in addition to the fact that it's altering, you know, how they look. You know, it alters how they feel. And people with Parkinson's almost always are stooped forward, and many of them are also tilted to one side. So the combination of those 2 puts an enormous force on your lower back, so that people who are subject to arthritis, and I hate to tell you, but 100% of people over the age of 60 have arthritis in their spine, okay? So having arthritis is normal. Not having it is abnormal, but obviously you don't want it. So back pain is a very common problem in the general population, but it's markedly increased in Parkinson's because the posture is so abnormal, and yet we have nothing for it. Medications don't work very well for that. L-Dopa is not a very good drug for posture, and so we see patients sometimes whose Parkinson's isn't so bad, except that they're really markedly stooped over, and it makes their life very difficult, and the medications are not very helpful for that. Next slide. And balance. So, you know, Parkinson patients have impaired balance, and the medicine sometimes helps that, but usually doesn't. So it's not very good at reducing falls. Next slide. And then, as I mentioned before, the non-motor symptoms don't respond at all. Next slide. Next slide. So I'm going to close here and answer questions. The summary of what I'm talking about, of what I've talked about, is that dopamine deficiency is very important. Dopamine deficiency causes a lot of the symptoms of the motor symptoms of Parkinson's disease, but not all. In addition, and you can think in terms of the importance of all those brain connections that I mentioned, the 380,000 cells, each of which connects to 1 million other cells, that when we give L-Dopa, as most of you know, there's a limit to how much better we can make you. That when we give you as much L-Dopa sort of as your brain can process, when we give you more, you just get side effects and you don't get better. Some of that is due, I think, to the fact that you've lost a lot of the brain connections, those million connections per brain cell, and you lost 50 to 80% of those brain cells. So the brain connections are very important. In addition to that, I believe that other neurotransmitters, other chemicals in the brain are very important for this, and we don't understand any of them at this point. So there's a lot of work that needs to be done trying to identify the importance of these other neurotransmitters, and with the hope that we can find drugs that will alter how they work. So, oh, you're going too fast. So we need to look at these other neurotransmitters in the brain to see if we can improve symptoms that currently don't respond to L-DOPA or the other drugs. The optimistic conclusion to this, then, is that therefore there are lots of opportunities for potentially dramatic improvements in the treatment of Parkinson's disease. Thank you. I'll take questions. Okay?